Hello, it's Dr. Shelley, and this is part 2 of a series of Parkinson's videos. I wonder why I'm doing part 1, part 2, part 3. Why am I doing so many parts? Could it be that Parkinson's is a focus? Parkinson's is a focus. It's a focus of every test everywhere, no matter if you're a nurse practitioner, an RN, an LPN, or you are in nursing school. So come on now, stay with me. I know it's a lot, but it's really good because what I'm doing when I update my videos, and certainly I'm going through all my videos because the quality of your NCLEX reviewer is that they keep the information current. Okay, so like what am I really saying? I'm saying that if you're a teacher, if you're nursing school, or if the videos you've been watching on YouTube are still teaching Mona, they are outdated. There is no more morphine, oxygen, nitro, and aspirin in the management of an MI. No, there's no more Mona. No. Instead, there's a bunch of other stuff that if you just click on my cardio videos, you can find out. We don't have time for that right now. We in neuro. So stay focused. Yes, so this is Parkinson's. Parkinson's is, as you know, based on part 1 video, is a neurodegenerative disorder. And what that also means is that if you want all the information on neuro conditions that are degenerative, you just need to go to my HETV on YouTube and focus on the playlist. By now, a lot of you already know how to find my videos because they're so organized, and you know the secret to really going to nursing school online for free is going to my playlist and pulling up any disease process or body system that you need. There's neuro, there's GI, there's respiratory, there's cardio, there's maternity, there's peds, there's growth and development, there's EKGs, there's cancer, there's burns, there's everything. So today we're focused on Parkinson's. Now, quick review. A quick review should remind you that Parkinson's is a condition that is not going to get better. There is no cure. It is progressive. It's gradual. It takes years to progress, but that's what it is. A quick review should tell you it's a movement disorder, an order of lack of coordination in the movement, jerky, uncontrolled movements, involuntary movements. It's a movement disorder as well. A quick review should tell you that with Parkinson's, the patient can absolutely, up to 50% or more people can have cognitive deterioration in which they have not just, dementia, but they can even have psychosis, hallucinations, delusions. It's bad, right? It's some serious stuff. A quick review of this disorder should remind you that this patient is at risk for falls and aspiration, and so you have some things to think about. When we did part 1 video, we also incorporated the clinical judgment model into the actual video. And just a quick review on that. Remember how that's designed. The clinical model with its 6 parts. Oh, and let me stop. No. Cut it out. No, not the video. Just you people out there. I need your ass to hit that subscribe button and quit wasting my time. I see you just sitting there. Oh, this good. She really know what she's talking about. Oh my goodness. No. Hit the subscribe. Okay, now where was I? Oh, yeah. Okay, so the clinical judgment model is 6 parts. Part 1 is analyze the cues. I lied. Let me start over. Part 1 is recognize the cues. Part 2 is analyze. I described the differences in those 2 parts of the 6-part clinical judgment model as being a case study is sitting before you, maybe in nursing school or for the NCLEX. And the case study starts off saying 15-year-old blah, blah, blah is admitted with whatever. That 15 was you recognizing the cue of an age. The analysis or analyzing that cue or the analysis of that cue let you know in your brain, because you're intelligent, when you thought about the recognition of the age, it wasn't just that 15 sounded like a great number. No, you analyzed it to mean, oh, she's only 15. The doctor will need to obtain consent from her parents, not her. well, she'll consent as well, but the parents have to sign off on whatever you're doing, test, procedure, diagnosis wise. The 15 age, if it's a female, more cues, right? Female, male, female versus male, cue. It's a recognition that a female of 15 could be pregnant. Another analysis of that cue, if you will, the 15-year-old age, would be the fact that you better incorporate growth and development principles into your answer. She's a child. You cannot forget that. So anyway, I'm just giving you examples, right? That has nothing to do with Parkinson's, but I'm giving you the examples. So now we're moving from part 1, Parkinson's video, on the recognition of cues and the analysis of cues. We're moving to part 2, and we're moving on with our clinical judgment to address the issue of prioritizing the hypotheses as well as generating solutions, which is step 4 of the clinical judgment model. So here we are. What the hell does prioritize hypotheses mean, Shelly? Well, you know yourself that when you look at different diagnoses and disease processes, they overlap, and many times you could misdiagnose one for the other. And while supposedly it's the doctor that diagnoses, he does not do it without your input and your, your hypotheses. I know in school they teach us nurses don't diagnose. Well, that's all bullshit, because reality is, while you may not formally diagnose to the point of billing for that diagnosis and writing that diagnosis, you definitely diagnose. Otherwise, what's triage all about? So nurses that I work with, they know good and daggone well when a patient has pneumonia. Yep. In fact, that conversation goes like this with the doctor. Send the page, await the call, answer the vocera, and let them know. Patient has a very moist cough. The lungs sound crappy. I hear crackles. Can I get a chest x-ray and a sputum culture? I really think this guy's getting pneumonia. So don't tell me how you don't diagnose, because yes, you do. Okay, so that being your mindset and understanding the role you play in caring for the patient and even figuring out what they have, that's all prioritized hypothesis means. Now, if you've been a nurse for 20 seconds or less and you got out of nursing school or you took the test before, you know what a big ass hairy deal prioritizing the hypothesis is. So your patient is going to come in with all kinds of interesting comments. This one in particular might come in talking about all kinds of secondary complaints, right? Maybe they got heartburn, maybe they're constipated, maybe they have a sore on their toe or whatever. Well, you better be more concerned when the pulse ox is less than 90, or they're anxious and irritable and restless or whatever. So you do have to know how to prioritize. So this particular part of this video is going to show you how to prioritize hypothesis. And when you're faced with a case study on NCLEX or your nursing school, this is the point where usually your case study is trying to figure out, do you know how to figure out one diagnosis from the other diagnosis that sound really freaking similar? So my example for you to help you process that whole thought process is cold, flu, pneumonia, ARDS. If you just have a cold, you better not have a fever. If you just have the flu, then why are you experiencing chest pain? If you just have pneumonia and you don't have ARDS, then your pulse ox ought to come up with oxygen. Boom. Now let's look at this and do the same thing. Because again, the cold, the flu, the pneumonia, and the ARDS sound a lot alike. And that's our problem with this diagnosis. Don't get it twisted. Even our wonderful doctors misdiagnose this patient. But we're going to try to get it to a fine science where we're somewhere in the ballpark. Here we go. Parkinson's disease is very similar to multiple sclerosis, myasthenia gravis, ALS, which stands for AMIO, I always tell you Amy, a girl's name with the O after it, amyolateral sclerosis or Lou Gehrig's, GB, which is Guillain-Barré, as well as Huntington's disease. So we're going to look at all of these to figure out, well, what makes Parkinson's so different? They're super similar. I'm not going to lie to you. So even after we do this, you're going to be like, okay, Shell Bell, if you say so. Here we go. The MS, or multiple sclerosis patient, it's an autoimmune disease that starts in the legs or the eyes. It is unilateral, but there's not necessarily cognitive deterioration. So then that means that when you look at Parkinson's, it starts in the hands and the arms. Definitely not the eyes ever. Didn't mention that at all. And it does start in the very early stages unilateral, but it quickly becomes bilateral in stage 2. So even though we know they are similar, if you know your 5 stages, which is stage 1 is unilateral, jerky movements or uncontrolled movements, tremors, if you will, of the hand or the arm, usually the arm. Stage 2 is bilateral. Basically, you're now doing both sides of your body that way. Well, this patient starts off unilateral, and it stays unilateral for quite a while. Okay, now let's move on. Myasthenia gravis. How does Parkinson's disease differ from myasthenia gravis? Well, myasthenia gravis starts at the face and moves down in a descending pattern. In fact, the first sign is not tremors of the arm. Oh, no. The first sign is ptosis or lid lag. You got a lazy eye. Remember that? Dysphagia, difficulty swallowing, slurred speech, even breathing can be impacted with myasthenia gravis. And there is no cognitive changes. That's very different from Parkinson's. Let's do another one. ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's. This is very different from Parkinson's. This patient's situation is super rare, whereas Parkinson's is actually number 2 in line with Alzheimer's. It's pretty common. There is a rapid progression. How rapid? Oh, honey, you are dead within 2 to 5 years of the diagnosis. That's not true with Parkinson's. It takes a long time. Gradual progression for Parkinson's to get you to the point where there's a problem. There is absolutely positively no dementia or cognitive decline. In fact, up until the day you die, you are completely with it. Very different disease. Not to mention, the early signs of ALS are similar, but all this makes it so different, you can definitely distinguish the two. But the similar signs and symptoms are twitches and fasciculations in the feet and the arms, chewing and swallowing problems, extremely weak and stiff muscles. Now, you don't have to sweat your jerry curl about all these differences, because I have a video for each and every one of these in my neuro videos. So don't get your panties or your shorts in a bunch. You know I've got more where this is concerned, okay? Now, Guillain-Barré. This is very different again. With Guillain-Barré, you are paralyzed within a week or 2. That is absolutely not true for Parkinson's. With Guillain-Barré, usually by 2 to 3 weeks in, you need a ventilator. With Guillain-Barré, it's usually triggered by an infection, respiratory or GI, or maybe even a flu vaccine of some sort. H1N1 flu vaccine was the most popular trigger. And it does start in the lower extremities, and it starts on both sides. And it moves right on up the body in an ascending type fashion. But the bottom line is you're paralyzed within a couple weeks. I mean, that's a big difference. Let's look at Huntington's disease. With Huntington's disease, this is big time genetic. In fact, it's autosomal dominant genetic. meaning only one parent has to have the trait and they can pass it down. It also starts really early. And I know I squished it in here a little bit, but hopefully my girl is getting it on tape. But it's between 35 and 45 years old, whereas Parkinson's is usually diagnosed after 60. Also, this patient's there's symptoms and signs and symptoms, I should have said. This patient's signs and symptoms do look exactly like Parkinson's, I'm not gonna lie, but the twitches and tremors and uncontrolled movements, also called in this patient chorea, they are very late signs. Before all those uncontrolled tremors and twitches and movements occurred, this patient was getting into trouble at work and in their relationships because of angry, irritable outbursts and emotional and behavior difficulties, very unstable in terms of their emotions. These were the early signs, and no, that's not the early signs of Parkinson's. So I am praying that that helps you with prioritizing your hypothesis, because a lot of times when you take a test, these will be compared and contrasted with each other. And you'll have to go, oh my God, I don't know the difference between any of these. It's very confusing, but I have it down for you, so you should be okay. Now let's look at something else. I told you that this video was going to be based on 2 of the clinical judgment model steps. Not the recognize the cues, that was the first video. Not the analyze the cues, that was the second video. Or I'm sorry, that was the first video, second step of the clinical judgment model. This video, which is part 2, Parkinson's, has 2 more. We just did this one. Now we're off to the number 4th one. So number 4 is generate solutions. And I can't stress to you how much this is probably the hardest part, one of the hardest parts of a case study, for you to think, what am I going to do as a nurse? Generating solutions includes basic care and comfort. And let me just say this, that is the #1 area of failure on NCLEX, because nurses don't remember or were never taught how to simply care for the patient, because our schools, if it's only 2-year school, which a lot of our nurses come from 2-year programs, associate degree programs, they only have 2 quick years to teach you all this stuff, and they cram in what they feel is most important, although they spend a lot of wasted time on math. That shit's wasted. You barely ever get any math on these tests. But they spend all this time on math tests, right? Meanwhile, back at the ranch, they're spending a lot of time when they finally get you into nursing on the disease and the signs and symptoms and the diagnosis and the procedures. They spend very little time on teaching you how to be a nurse. Basic care and comfort is the #1 area of failure on NCLEX. What that means is, how do you do what you do that's different from the doctor, different from the pharmacist, and different from physical therapy or whatever? How do you take care, basic care, and comfort your patient? That's it right there. Okay, so it's your plan of care, not the doctor's orders. That's the difference. So let's look at what you, the nurse, is going to do for this patient. This patient is a huge, tremendous safety issue. You know, on Maslow's hierarchy of needs, safety is #1. So you have got to implement false precautions immediately, because this patient has coordination issues. The patient has balance issues. The patient can have freeze ups where they can't move, and right after the freeze up disappears, they're at very high risk of falling. They have all these issues. They are going to be really high risk for a fall, so much so that in the hospital environment, I would say that if you have a patient with, up ad lib, which means, they can go walking to the bathroom or the hallway or whatever, I would say they need somebody on standby. And if they don't have anybody on standby, which is somebody walking with them, then they definitely need their assistive devices. You can have a laser pointed cane. You can have a cane with a rubber bottom on it. You might even get to the point where this patient would do better with a walker. Remember that the cane is more for balance and, like coordination a little bit. It does not provide a lot of big time support. It's the smallest on the list of support devices, right? So the walker is a much better device for support. So if the patient is experiencing moderate Parkinson's, oh, they're definitely going to need a walker. You're going to have to remember the raised toilet seat. You're going to have to remember the grab bars in the bathroom and in the shower. You're going to have to remember that this patient really has a hard time controlling their movements. So eating is difficult, and they do have special utensils for that. Dysphagia precautions, huge. You know them, but let's just review them, right? When you're getting this patient to eat, you're going to make sure that they're sitting upright for 30 minutes before, during the meal, and after, 30 more additional minutes after. You're going to make sure that the food is soft. We may have to use a thickener for the food so that it's not putting the patient at risk for aspiration pneumonia because, you know, just thin liquids sometimes don't go down right. You can't be given crumbly foods and crackers and things that might choke the patient. So soft, mechanical, soft diet. By the way, Meals on Wheels is considered mechanically soft. So if they're in the home environment and need meals delivered, Meals on Wheels does follow the mechanical soft diet. The dysphagia precautions also include the fact that we tuck our chin and flex in order to swallow. I want you to try this at home. If you go like this, you can't swallow. But if you go like this, you absolutely can swallow. So that's some of the tips you have to remember. This patient may even need, depending on what stage of Parkinson's they're in, they may need a speech language pathologist to evaluate their ability to swallow. You yourself may give them a swallow test to see if they're coughing violently after just simple water. These are all the things we do, right? The nutritionist needs to be on board because this patient can come in and be quite malnourished because they just don't have the appetite as well as they don't do well with certain foods. So you got to think of that. Physical therapy and occupational therapy will help with adaptive devices. It's usually a physical therapist that may be able to determine what level of assistive devices they need, walker versus cane kind of thing. The occupational therapist can give them resources as to where to buy utensils or where to find the utensils that they would need to properly feed themselves, given that they always have tremors, okay? The diet is important because this patient is going to experience constipation, and so high fiber diet and pushing fluids is important. And be careful. You know, when you say things like push fluids, that ain't saying shit, right? So when I say push fluids, it means that the poor student has to know what normal fluid intake is. And as long as there's no restrictions for this patient, remember that a normal fluid intake for all of us is about 2 liters a day. Well, this is an elderly patient. You kind of got to remind them to drink those 2 liters a day to keep from being constipated. That with the high fiber foods should help quite a bit. Now, I just want to distinguish between basic care and comfort versus you're thinking more like a doctor. Notice here I wrote high fiber push fluids. I would be in trouble on the test if I didn't have high fiber push fluids and instead this was all gone and all I had here was a stool softener. That would show that I don't know how to be a nurse. It's nothing wrong with the stool softener. This patient's definitely going to be ordered a stool softener. What's wrong is that as a nurse, you're supposed to know the natural ways to get this patient to have proper bowel movements daily, if you will, okay? So high fiber, push fluids, and again, they definitely will probably be on a stool softener, but that is not called basic care and comfort. That's called a doctor's order. You feeling me on that? Okay. Now, the assistive devices we've talked about already, walkers and canes. You're gonna have to monitor this patient for orthostatic hypotension and teach them to rise slowly, no sudden movements, because they can get dizzy based on all the different medications that we use to treat Parkinson's. And so we say they shouldn't stay in the shower, the warm shower, longer than about 10 minutes, because You know, what warm water does, it vasodilates your vessels, and vasodilation causes your blood pressure to drop. They're already at risk for that with the different medications we treat them with. There's not one medication that we give them that's not going to cause them a little bit of dizziness or low blood pressure. So running up and down steps or getting up fast out of bed and running to the bathroom, nah, it's not a good look, because they're going to fall. Okay, so that's just a little bit of your, for free. Now, this respiratory status, don't forget what I taught you in the video, in part 1 video. Parkinson's part 1, remember we said that these patients generally will die from a respiratory failure. This patient could come into your hospital with signs already of aspiration pneumonia. They could have some issues with pneumonia, just regular community-acquired pneumonia. Their muscles are not working as well, so coughing and deep breathing may not be part of what they do naturally. And so we have to worry about respiratory status. We also have to worry about gag reflex and all that. We talked a little bit about that earlier. Now, let's make our patients' lives easier, right? There's no way this patient should still be trying to button things up and zip things up and tie things up. No, God, no. It should be as simple as either Velcro, fasteners, or whatever, because can you imagine this tremor that you have and this pill rolling that's going on with this poor patient and trying to button stuff up, snap stuff up, zip stuff up? Nah, it ain't gonna work. Okay, so think of that even in terms of your education of the family. Freeze up advice. Here's the deal. These patients can be trying to walk and their feet literally freeze to the floor. At that point, they just need to stop and let that symptom kind of go away and understand that right after that, they're at really high risk for a fall, so they need to be very deliberate in their movement. They also need to know that sometimes it will help if they get froze up like that to try to turn or even, get this, walk backwards. We'll get them out that frozen kind of stance, right? Either way you look at it, this patient has a shuffling gait. Mom and them call it a dragging your feet. Tell them to pick up their feet. They're going to look weird, but you just teach them to pick up their feet like in a marching type of fashion. Just deliberate movement of those feet will help. Now, this patient's going to need a support group. You can imagine, given the diagnosis of Parkinson's and always shaking and tremoring and all this other kind of stuff that goes with it, the depression, the isolation. Don't forget your Erickson stage, which is ego, integrity versus despair. It might be a really great idea to get them in a support group where they can be among people who have the same kind of situation, find out how they're coping. Just being in a group period is going to help their mentation. So I want you to really remember that. Also, the patient needs to move in a deliberate, stress-free way, and that's called yoga or Tai Chi. It decreases the stress, both of these types of activities, and it provides for deliberate movement. I mean, for a little while, I tried to find like a Tai Chi instructor in Cleveland, Ohio. It was just like a moot point. Like, I couldn't find one. So I, myself, all of us, get your ass out there and find you some Tai Chi, honey, or some yoga or whatever. Because if nursing school ain't stressful, I don't know what is. So we could all benefit from this. Now, you are going to have to monitor this patient's bowel movement pattern because this patient is at risk for constipation. So it's very highly likely that when they enter your hospital setting, it's been a little while since they went poop, and you've got to monitor that. And we already said push fluids and, fresh fruits and veggies, high fiber meals, blah, blah, blah. High fiber, by the way, is 3 grams or more of fiber per product that is supposed to have fiber. So the other day I was buying bread and I saw this really soft but somewhat delicious looking bread, and it said, whole grain. It always say that, right? But they say that on all of them. You got to read the fiber content. I read about 6 loaves of breads before that, and it said 2 grams. Oh, y'all so full of shit. This is not whole grain for 2 grams of fiber. The one I brought home, which was really good because I had me a bacon, cheese, hot dog, ham, pork chop sandwich, sort of. But the one I brought home had 4 grams of fiber. Remember what fiber does. Fiber decreases your glycemic load, so it keeps your blood sugar in check and balanced and low. And it also keeps you regular, so you get these toxins and shit out your body. It's real, y'all. Y'all have to get you some damn fiber. Okay, now look, I ain't got all this kind of time to play with you. So what I'm going to do is see you in a little bit with the last 2 clinical judgment models. But I know some of y'all ain't seen video 1, so I'm going to go on up in here and try to give you some more freebies. Because I keep telling you, if I remember, after every single video, I give y'all babies a way to get my handy dandy little oh my god packet. And let me just show you that bad boy now. This thing is free. It's complimentary. It's an entire study guide. It's got delegation, prioritization, who you see first. It's got select alls for bleeding precautions, neutropenic precautions, seizure precautions. It's got maternity and pediatric quickies, even neonatal vital signs. It's got nutrition, positions. It's got everything your little ass need. Okay, so quit acting brand new. Go ahead and hit me up. Here y'all go. This is for free now. I ain't asked you for no damn money. Don't act like I did. Videos for free. Oh my God, packet for free. Well, I ain't free, but I mean, you know. So here we go. Hit me up, y'all. I got something for you. Deuces.